Hi everyone, and welcome to this Strategy Unit webinar, where we'll be exploring what happened with infant feeding presentations in emergency departments during the COVID-19 pandemic. We'll be discussing the findings of a recent study, which was a product of a collaborative effort across healthcare staff at the front line, academia, and NHS analytics expertise, led by Stephen Wyatt from the Strategy Unit. We'll explore what was happening with infant feeding during the pandemic and why, what we can learn from how services operated, and how we might future-proof for another pandemic or similar situation. We're speaking to some of the co-authors of this piece of work, which are Patrick Aldridge, a paediatric clinical lead and consultant, Sankara Narayanan, a consultant neonatologist, and Samantha Ross, a GP from Glasgow. So just to begin with, last year, the Strategy Unit and colleagues from the Health Foundation and the Nuffield Trust published a paper highlighting the dramatic reductions in emergency department attendances across other causes during the first and second lockdown. This wasn't the case for the presentation of infant feeding. So following the publication of that work, we had an interesting email from Patrick Aldridge, a paediatric A&E consultant at Frimley Health Trust, with an interesting observation. So Patrick, what is it that you had noticed?
Thanks very much. So during the start of the pandemic, we noticed that, as with everyone else, attendances dropped off quite dramatically. However, in the babies under 1 month, locally, we noticed that hadn't really happened. And anecdotally, it felt like the number of babies attending our department had actually increased. We did an analysis of this, which showed we were kind of right, that the babies had kept coming. And we thought it was due to a lot of them was infant feeding problems, because lots of babies and mothers, newborn babies with their mothers, were presenting with feeding issues. These would be things such as reflux or jaundice, or literally just I'm having problems feeding my baby. And some of this we felt was probably due to the lockdown and lack of sort of access to services, but we didn't really know. So I somehow found out about the NHS Strategy Unit, I think because of the paper that you'd done, and contacted Stephen to say, look, locally, this is what we've noticed. I really think you should look into this, and had a chat with him, who then he then analysed the sort of national data set, which supported the observation that babies under 28 days, under 1 month, had increased a little bit, or more pressingly, it hadn't decreased along with all the other age groups. So we agreed that we would write a little little blog about this, setting out what we thought were the causes for this, and to see if there was anyone else out there who had similar observations and experience.
And we got quite the response from sort of Twitter, didn't we, Patrick? And I think one of those was from Sankara Narayanan, who was a neonatologist, and is a neonatologist, I should say, at Watford General Hospital. So Sankara, what was happening in your trust during COVID?
Yeah, thank you. So yes, I reached out after seeing the information of the blog on Twitter, and then we've been doing some work locally. So I work as a neonatologist, but also pathways for readmission to the neonatal services are through ED. I also have interest in looking at the patient flows for neonates 0 to 28 days that are coming through to the hospital. So we have a structured dashboard. So as the pandemic hit, and all these measures were put in place to limit COVID transmission, the shock of the whole thing means that for the first week, from 23rd of March till end of March, we had significant reduction in all attendances to A&E, adults, children, and also neonates. But we continued to monitor that trend. But by second week of April, we started seeing the children were still gone. They're not coming to A&E, but the neonates 0 to 28 days, babies started increasing. Exactly like what Patrick said, the most common reasons were feeding problems, jaundice, reflux, difficulty in breathing. Another interesting thing we noted as well was that most of these attendances, the babies were not needing many interventions that could only be provided in the hospital. Most of them were reassured and discharged. So I think about 85% did not need any interventions after first assessment. They were discharged. So we continued to monitor this trend, and as Patrick said, we couldn't really be sure what was causing this, but an intelligent guess was that the service disruption to the community-based postnatal services got to be the reason. So we started reaching out to our maternity colleagues and midwives and health visitors in primary care, and we understood that to limit transmission of COVID, they had stopped the first face-to-face visit and converted that to a phone call, and then subsequently reached out on day 5 for a face-to-face visit, and only about 60% of those face-to-face visits were happening because either the parent was not letting the healthcare professional into their house, or there were some risk assessments that were taking place. So we rapidly adapted the system, so highlighted the problem to the local commissioners, and we reeled back on those recommendations and reinstated the face-to-face visit. So by May, June, our numbers had gone from about 35 to 40 units coming to our ED to about 120 by May, June 2020, so nearly 2.5 times. But after implementation of these measures, the numbers went down, but still higher than the pre-pandemic. But around this time, I saw this Twitter message and I reached out, and I could, in a way, was relieved that what we were suspecting was confirmed in other places as well. And then we worked alongside Patrick and the NHS strategy unit in looking at the national data set. So yeah, it was a very interesting and collaborative work. I think more importantly, it helped us identify and almost reaffirm the value of this community-based support that is there. And when those that kind of support was sort of interrupted suddenly, sort of unintended consequences that can have, it highlighted that to us.
Yeah, and interestingly, they sort of setting the scene for, I guess, what was happening within maternity services and in the community as well, which kind of brings me on to yourself, Samantha, as a GP with a special interest in infant feeding. What is it that was happening in general practice at the time? And what about the other sort of community-based support that was available for new parents?
Thanks very much, Mahmouda. Yes, I work in Scotland as a GP, but I have to say that many of the themes that have been mentioned certainly chimed with me. And when I saw Steve's message on Twitter and read his blog, I thought this is exactly what's been happening up here as well. And that's why I got in touch. So as a GP, like the others have said, our service provision during the early start of COVID was really prioritised on reducing transmission, and a lot of remote consultation was being put in place. And the 6 to 8 week check was also being deferred in some settings, which wasn't ideal. As a GP with this interest in infant feeding, however, I realised that there was obviously an issue, and speaking to colleagues in our infant feeding service, we noted that there was a marked reduction in referrals to the service, which would have traditionally come more from health visitors rather than GPs. And this was partly due to the fact that health visitors' services were depleted. Some of them had been redeployed to work in acute services during the early part of COVID, and there was a difference in how they were relaying the service, as Sankara has mentioned. But I think in Scotland, the universal pathway was largely maintained. So some visits were taking place. However, it was really noticed that there was a reduction in breastfeeding referral through to the infant feeding service. So I think this has had a knock-on effect on actually recognising problems as they develop. So feeding assessments are really important to do in the community. And as Patrick has mentioned, or as Sankara has mentioned, I think reassurance is actually a mainstay of what we do in primary care. We diagnose reflux, but we also ensure that it's not inappropriately diagnosed as well, and we give appropriate feeding support. If that support isn't there, then I think mothers don't have any other option other than going to urgent care services. And that's actually something that I was interested in even before COVID. I was really interested in the use of how families turned up at urgent care with feeding problems, which wasn't necessarily appropriate. So I do have an interest in developing structured, streamlined support services, breastfeeding support services. I'm really aware that third sector breastfeeding support services did maintain a presence. They provided remote services which were utilised, but that proportion of women who used those services tended to be the more not disadvantaged groups. In other words, women who had access to IT technology, who were literate in those technologies, they could use those services. But that meant there was going to be a gap with vulnerable groups, underprivileged groups, perhaps groups of different ethnicities, and groups who had increased deprivation wouldn't necessarily be able to access those technologies. So that's important, but I think it was only one part of the picture, and unfortunately it meant that other families and other women fell through that hole and had to access care in a different way.
Okay, and just sort of coming back, I guess, going back a little bit. So what was the sort of a state of the use of these services before the sort of pandemic, and what was the kind of striking change in sort of the behaviour of patients that you saw? And that's up to anybody who wants to sort of come in.
Well, I could just say that before the pandemic, certainly we had a lot more face-to-face attendances in general practice. We are the front door of the NHS, so in some respects a bit like A&E, but we handle routine non-urgent cases as well as urgent care, and unfortunately that disappeared because total triage was being deployed in many primary care settings, which meant that some families probably were inhibited about contacting primary care services. We may have felt as clinicians that it was working well, but I think perhaps in hindsight it wasn't. And I think the use of remote technologies is a double-edged sword as well. I think as a GP, we felt this is actually really useful, but I think I have an interest in this area particularly. I've been carrying out a survey locally, and I think some of the GPs at the time of the initial pandemic noted that remote consultations were really good, but they actually specifically wondered if it had any use in terms of providing support for infant feeding. And I think a lot of the GPs I surveyed felt that it didn't really, because a lot of that required face-to-face assessment. So that's from my perspective.
I think I entirely agree with you, Samantha, on that one, because we compared the number of infant feeding referrals to the hospital-based infant feeding advisors. We have 3 of them pre-pandemic to during the pandemic. Actually, the number of referrals increased because the access became easier because it was remote. So they were not working in the postnatal wards or going out into the community. Instead, they're sitting in an office. And actually, if you look at their logs, they were doing nearly 3 times more infant feeding support virtually, but actually it was not making any difference to the number of attendances in the first 2-3 months until we went back on to the face-to-face day 2 to 3 visit, particularly for slightly higher risk newborns like early term births and low birth weight babies and etc. So I feel that virtual consultations and virtual delivery of healthcare is something that we've all learned in this pandemic, but it may not necessarily work for certain aspects of healthcare delivery, particularly infant feeding support. I feel strongly that's the case. Thank you.
Yeah, I think what this paper adds or has clearly shown was that you are more likely to attend hospital across the UK if you were a first-time mother, if this was your first child, and from the coalface, as it were, that's what we were seeing a lot of mothers who just they didn't have any other options, kind of thing. And a lot of the time they just needed someone to say, hand on the shoulder, you're doing well, you're doing fine, your baby is fine. And that's, video consultation, so forth, is really good for certain patient groups, I feel. However, in others, someone on a video telling you your baby's fine just doesn't quite cut the mustard. And that was that came through with what we were seeing.
And I guess it's interesting because whilst emergency department attendance is reduced pretty dramatically and systematically with the pandemic for all other causes, it was that the sort of presentations within infant feeding sort of issues increased, and that obviously implies the sort of growth of that unmet need that you've all sort of described there. So Patrick, there you've kind of described, I guess, very well about what the sort of paper shows. So going on from that, what do you think we should actually take from all of this for now, but also should there be another pandemic or a lockdown or another similar situation, what can we sort of learn from this?
Do you want me to go first?
Yes, please do.
So I think this paper shows a number of things. Firstly, is that there are a lot of babies, hundreds of babies across the UK, attending hospital every week with feeding problems, and this was there before COVID. And the coding that we did, the patient group that we searched for, is a very tight group, which was reflux, jaundice, and I've forgotten the other one, which is really bad. But it's a tight little group, and it is highly likely to be an underestimate of the size of the issue that we have. What the paper's shown is that during the pandemic, this demand increased quite dramatically. People were being told to stay away from hospital, and people were bringing their little babies to hospital because they didn't feel, this is a lot of presumption, that they didn't feel there was any other options for them. Okay, I think it adds the fact that face-to-face for certain patient groups and demographics is vital. Okay, that video has its place, but that face-to-face contact is really useful. And then it's about in future pandemics or future issues, what do we do? And I think it is, don't forget the babies. Okay, don't forget the families. You had lots of people who are very isolated, and we're still seeing the ramifications of a lot of that in our healthcare system at the moment. The sort of other point would probably be that like at our trust, we've introduced something called the Mama's Line, which is a sort of a telephone triage service, 24/7 for sort of babies, for parents up to 1 month of age to contact to try and see if that's going to help reduce the number that come to the emergency department. It's early days. I believe other trusts already do it, but it's sort of advancing the triage system, the filters, to try and see if we can reduce the number of babies that are coming to hospital. I do think that the community services or availability of services for families, that there is something in that. As I said, there are hundreds of babies coming to hospitals across the UK, so there is definitely an already unmet demand, and it's trying to dig into what the best way of dealing with that is, and that's slightly outside of my realm of influence.
I guess that's where we probably come to you, Samantha, in terms of, I guess, what do you think we should take from this from the perspective of sort of primary care and community services?
Of course, I'm going to say better resourcing, but I think, more importantly, I think streamlining services so that primary care, secondary care, urgent care, and third sector care are actually all joined up. And I think just having that more effective communication, because I think that wasn't there even before the pandemic, and having access. I think a lot of my GPs locally weren't aware of all the services that were there. Secondary care in our area has really stepped up. They've provided more information on pathways to referring infants with feeding problems into the service. They've made that more widely known to all practitioners. Making sure health visitors' roles are preserved or protected. Protecting their roles during a pandemic is really important, so that they're not all going to be redeployed in the next pandemic, that they're still there to look after families, because that's really important, as Patrick's saying, really to make sure that the babies aren't forgotten. And I think just in terms of communication on early discharges postnatally, I think that would be really important for the community to be aware if there are any problems, so that we can troubleshoot and help to ensure that those problems don't snowball. So vulnerable families, of course, I think having an antenatal plan in place is really important, and that's, that should still be carried through a next pandemic. Hopefully there won't be another pandemic like this one, or we'll manage it better. But and also total lockdown. I don't know if we are going to ever do that again. Obviously I can't. That's outside my experience as well in terms of my knowledge on these things. But I think we would probably try to maintain some kind of service in primary care going forward if there was another pandemic, so that there would be some face-to-face assessment and we wouldn't completely shut down, because I think that was probably a mistake in hindsight. But I think it was the fear of the unknown that probably drove that. And certainly the 6 to 8 week check is really important, and I'm glad to say that that's back, and it's been promoted by many groups, including the RCGP, just to try and make sure that service is in place, because it's really important as a first assessment. I know by the time we get to 6 to 8 weeks, a lot of the problems are already in place, but I think that's important from a GP's perspective to have a look at babies at that stage as well.
And Sankara, coming to you, because you described a few changes to services, didn't you? So kind of what did we sort of take from that and the changes that you sort of saw?
Yes, so like Patrick and Samantha said, I think the problem was already there. Infant attending ED to get feeding reassurance and support is an inappropriate, use of A&E resources. Pandemic just highlighted the problem as the health system went into a shock and lockdown, etc. For me, I think we could see that as a responsive healthcare system, we should develop systems and structures where we continuously monitor these sort of patient flows system-wide to understand unwarranted variations. Even going now coming out of the pandemic, going back to the normal whenever it is going to be, I'm sure there will be variations. In Patrick's trust, this attendance might be 8%, and in my trust it might be 16%, and there might be another trust that's even higher. But understanding these variations and mapping them across to the triggers or the drivers, like lack of community support services, will be really useful, I think. And also, I think training and reconfiguration of the pathways to ensure that we maintain or retain these value-added sort of steps of community support in any future pandemics or any other disasters or events that put us in sort of similar situation in the future. I think that will be really useful.
I think that's sort of coming on from that, I guess. Where are we now? So what does the scene look like now? Have things sort of returned back to normal, Sankara, or what are they looking like at the moment?
Interestingly, I thought as we sort of reopen the services, these numbers will go down, but actually it hasn't. I think I would like to hear from Patrick about this. In our trust, if we include our sort of minor injury or urgent care type attendances, the overall children's attendances to ED is about 20% higher than the pre-pandemic. After the services started opening up, the numbers started going up, and this is closely followed by neonatal attendances as well. The most common reason is jaundice, and then feeding problems, reflux, and minor illnesses like parent is not sure about the baby's breathing, and those kind of issues. my impression on this is that it's probably because the staffing constraints and the disruption and probably depletion of the workforce. We are seeing the effects of that now going sort of post-pandemic. Probably this will need a very much a coordinated approach as we're moving into integrated care systems. I'm hoping that we will all work up jointly here to address the issue.
Thanks, Sankara. So I guess, Patrick, how does that sort of relate to how things are for you now?
So yeah, so our numbers are all over the place, to be honest. Sometimes it's down, sometimes it's up. It's an unclear picture at the moment, would be the honest answer. It's with regard to the under 1 monthers, it's probably stabilised a bit, but we've also introduced this, as I said, the Mummers line, which has sort of gone through. We're sort of one of the ICS sort of pilot or early adopters or whatever. So we sort of, back when all this started, we sort of took it to that environment and said, look, this is a problem. We need to do something about it. And it's been a bit of a long road, but that's the sort of origins of this this initiative. But it's early days, and there's definitely babies still coming with feeding problems. That's just, the issue has not gone away. Like we said, it was here before COVID, and COVID just highlighted it. It sort of shone a light on this sort of little group of babies who, in an ideal world, as Sankara said, would be best not coming to the emergency department because it's an emergency department, but for the public, for that family, that's where they need to go, because that's where they're going to get what they need, and that's emergency departments across the board for lots of different things. But it's about trying to create pathways for these parents to go somewhere else, which may be more appropriate.
Thanks, Patrick. Louisa, thank you for joining us. I know you've sort of just popped on now, and we're sort of coming to the end of the webinar, and hopefully we'll pick up with you a little shortly. But just from your perspective as a senior lecturer in epidemiology, I guess what does the sort of scene look like for you now, and what can we learn from the pandemic in terms of what we found in this piece of work, particularly with a sort of focus on sort of breastfeeding and the support services available there?
Thanks, Mahmouda. I think this has been an incredibly interesting piece of work to collaborate with various specialists and experts, especially clinicians that see this on the ground, and then snowballing from their direct experience on their trust to actually representative data for a large proportion of trust in England. And really the data is now showing how the importance of breastfeeding support and infant feeding support in the very early days at large scale, and also the preservation of this vital support during emergencies such as the pandemic. So breastfeeding support in England is very patchy at best, and that's to do with the fact that it relies heavily on community and voluntary organizations that are not homogeneous and present at the same level across the population, across the geography. And this means that if one particular organization or one particular area has a lack of volunteers during a certain time, then support can decline quite dramatically. And this has really severe consequences for families that need that vital support in the early days. Obviously, this was combined during the pandemic. It was impossible to do the same, to offer the same level of face-to-face support, and many volunteers had to be redeployed and do other things. And this happened at the same time as the majority of community support for infant feeding and for infants in general offered by health visitors also had to be redeployed. So we were faced with a combination of disruptions in care, both during hospital stays for mothers, including mother-infant separation, which heavily impacts on establishment of breastfeeding, and also disruptions in community care when mothers and babies return to their homes. So this was all very obvious, very predictable, and observed in anecdotal ways, but being able to look at the data from a population perspective, which is part of my job, really allowed us to put a number on the importance of this phenomenon. And it'll be really vital that we start acting on this breastfeeding and infant feeding support more seriously, because it can't rely on community and volunteer organizations to the extent it does at the moment. So when Patrick was talking about pathways for these parents to be able to access support, also both in a routine way, but also in an emergency situation, we need to be able to train lactation consultants and breastfeeding supporters, and join up the dots between primary care and this type of support community.
Thanks, Louisa. I think that's a great note to sort of end this podcast. So thank you all for your time. Thanks, Patrick, Sankara, Samantha, and Louisa. This has been a great example, I guess, of collaboration across sort of analytical and clinical expertise coming together to really better understand health issues. So you can find the sort of links to the paper that's just been published in the description below, and on the Strategy Unit website, which is www.strategyunitwm.nhs.uk. And if anybody's got any questions regarding this piece of work, you can contact the head of our research and policy team, Stephen Wyatt, who led on this piece of work, and his details are also available on the website. But thank you for listening, and hopefully you've learned a little bit more about this work, and you can check out some of the content. Thank you.